Ladies and gentlemen, thank you for joining us on our show, thelatestwith.com, where we try to have an open forum of discussion on the latest with in terms of stem cells and regenerative medicine. On today's show, we have Dr. Warren Sherman, who is the Director of Stem Cell Research and Regenerative Medicine at Columbia University. Dr. Sherman has been a pioneer in the area of developing cardiac therapeutics and over the past several decades. And he was the first person to begin the work on injecting stem cells in the heart. He's developed several catheters. How I met Dr. Sherman was we were at the IC3D conference, which he organized. And this conference, I met him in New York, and we learned a lot about the cutting edge. Basically, almost anybody who's anybody in this field was there at the conference. So with that said, maybe Dr. Sherman, maybe you can tell us a little bit about your background in case I made a mistake in the title, and also a little bit about the conference before we dive into some of the issues and some of the questions that people will be talking about.
Sure. Well, I want to thank you, Tom, and your group for having me on the program. I think it's a great opportunity to be able to talk openly and candidly about some of the things that we heard last week, as well as many of the things that have been going on for the past 10, 20 years. I'm a clinician by trade and by original interest, and took a mid-career diversion when one of my fellows, at the time I was at Beth Israel Medical Center in New York, went to hear Doris Taylor speak on skeletal myoblasts, and came back and created a visual image of hearts being grown in a field of petri dishes in the laboratory. Of course, that's not how things were done then, nor now. But there was a switch that was turned on in my thinking, in my brain, that has been a propelling factor in what I do and have done for the last 12 years, really. So this goes back to 1988 and that period of time, when the field was just in its infancy. And I was fortunate enough to develop an interest, to have the time to be able to travel and meet with people who were also gathering momentum in terms of regenerative medicine for mostly cardiac disease, not so much for critical limb ischemia, as you talked about last week with Dr. Amit Patel. But nevertheless, it was an opportunity. And I jumped all over it, as it turns out. Helped a company called BioHeart develop a catheter that was used in some of its early clinical trials for injecting cells into the heart, and got to meet many, many bright, hard-working investigators, both on the clinical side and the preclinical side, over the course of a period of years, such that when the time came to treat the first heart failure patient with non-surgical techniques, the first surgical delivery of cells had occurred in the year 2000 or so, or the year before. The first catheter delivery of muscle cells into the heart occurred in 2001 in Rotterdam Thorax Center, and I was due to the work with BioHeart and its team, became involved in that very first case. And from then we moved the technology here to the U.S. and we started phase 1 clinical trial in 2003, and followed that some years later with a phase 2-3 study with placebo, etc., using the same technique, using the same cells in patients with class 3 to 4 heart failure. So it's been a real as I said, opportunity. I've learned a lot of basic sciences that I wish I had taken time out to get a PhD along the way, but that wasn't to be the case. And I leave a lot of that work to those who are knowledgeable. My role, as I see it, is several-fold. First of all, to help bring technology, biologic side, and the delivery side with catheters into the late translational phase, meaning the phase that occurs just before moving into clinical trials, and refining the injection techniques and all the methods that are necessary and underlie the clinical protocols that are written. And then to move forward and participate in the clinical studies as well. And that's been a great opportunity because I've, as I said, not just worked with myoblasts and the company that has been producing those for years, but also other cells, many of which you had discussed with me last week and others to come. Mm-hmm. Around 2003 or 4, I felt that the field really needed to have its own conference. To that point, most of the stem cell meetings, as they were appendages or sections of larger national meetings, which meant that a lot of good science was presented on all sides, but one had to wait out 5 days and hear 1 or 2 sessions on one day, and then walk half a mile to the other end of the conference hall to hear someone else, and it really needed to be localized. And we had a one-day symposium when I was still at Mount Sinai at the New York Academy of Medicine, and bridged the basic and translational and the very early clinical studies that were going on at the time, and covered it in one day. Now, Tom, I know you were at the meeting last week, and we covered a lot in a day and a half. Imagine adding some basic sciences to that whole mix and covering it in one day. It was a sprint, but it was a very good meeting. And from then on, I essentially had it annually. There were a couple years that I had to let it drop out. I moved to Columbia in 2005, and the timing wasn't quite right. Then, of course, the economy, being what it was 2 years ago, led to my having to cancel the meeting for 2010. So this is the 6th in 8 years of the meeting, and it's evolved in a very important way, which we can discuss if you'd like.
Yeah, absolutely. Thank you. Okay, just as we started talking, we got a whole bunch of questions, so we'll go through the questions very quickly. Let's start with the first question that is more applicable, that is relevant to what you're doing, which is here. The myoblasts that you were using initially, were those from the same patient or were they allogenic?
No, virtually all of the skeletal myoblast studies have been autologous. There was some work done with allogeneic, that is to say donor myoblast cells in Russia, but it did not continue. So virtually every paper of any significance, and we're still talking small number of patients enrolled, are with autologous cells.
Excellent. The other quick question, has anybody ever gotten worse after stem cell therapy, specifically in the heart?
Absolutely. And the mechanisms by which patients get worse are multifactorial. Some, and most, as it turns out, are due to the natural progression of the disease itself.
Right, so not because of the cells, I think what they're wondering is treatment-associated adverse reactions.
Sure. No, I mean, it's a good question, and of course, every phase 1 study has safety as its primary endpoint. Nevertheless, despite the numerous ways that cells have been administered both in the operating room or in the catheterization laboratory or intravenously and on the floors of the hospitals, it's been very, very hard to point to the cell, the population of cells being administered, as eliciting any important adverse effects. It's more likely, as I said, over time for the disease process that the patient is being treated for to lead to problems. Second, in terms of frequency, is the delivery method itself. So from the catheter standpoint, for example, we're looking at embedding a 25 or 27 gauge needle into the wall of the heart. And that has to be done in certain clinical conditions very carefully. So there have been, even so, a very small handful of adverse events related to the injection technique. Mm-hmm. So the cells themselves appear to be very well tolerated when given virtually in every way that they have been in clinical trials.
Mm-hmm. No, this is very good. As you know, our company, MediStem, is right now we filed our IND with the FDA for our universal donor stem cell from the menstrual blood. Right. And of course, the big concern of the agency was tumorigenicity. So not only have we done now and completed the studies they required, which includes acute and chronic administration, histology, but as part of our IND, we're conducting a thorough literature review of everything that's been done in general with mesenchymals, because, as you know, what we are trying to do in this field, I mean, the lowest hanging fruit, in my opinion, is critical limb ischemia, because the leg's going to be amputated anyway. And the outcome that we're looking for is primarily angiogenesis. Now, you being a clinician, you know a lot of these patients are older patients that have a possibility of a submalignant tumor or a previous or a tumor that's not detectable. So the biggest concern, obviously, of the agency and of us when we embarked on this mission is we're developing angiogenic cells. Could these perhaps be facilitator cells to the tumor growth? Quite strikingly, what we published, and we still do not really understand the mechanism, when you inject our endometrial regenerative cells into animals with glioma, in the C6 rodent model of glioma, you actually see inhibition of the glioma. Now, how that works, I can give you a bunch of theories, but it's a very, very interesting concept. Okay, really quickly, so we can continue our discussion. Let's go. There was a couple of questions. I don't want people to feel left out. And one of the questions was if you or I know of anybody who's used stem cells in Parkinson's disease.
Oh, yes. I mean, there have been a number of studies that go back 5 or 6 years that have delivered cells of one form or other to patients with Parkinson's disease. Mm-hmm. And some of those cells are neurologic in their basis and secretory and dopaminergic, etc. There's also a population of patients who are being given bone marrow-derived cells, not necessarily with an understanding that angiogenesis or that a shortage of vessels is at the core of the problem in patients with Parkinson's disease. But such is being done, and there isn't, so far as I know, and I've not kept up with the most recent Parkinson's literature, there hasn't been a phase 2 study of any substance to look at this and provide an answer.
This is a very, very interesting point because I do remember some of those studies on Parkinson's where they were using fetal-derived cells. Now, if I remember correctly, and you may be too young to remember this, but
You're too kind.
there was a study, and maybe I imagined it, where they were doing placebo control, drilling holes, I think, in the brain of Parkinson patients. Is that true? Did that study really take place, or did I imagine that?
Yes. No, I don't think you imagined it. But I couldn't cite the data or the results.
Yeah.
But again, it was fetal-derived cells, which raises eyebrows when one talks about it for the more common diseases. We have to be very careful from a political standpoint, from other standpoints, as to how we source cells. Where do we get them?
Exactly. But another very, very interesting point with that, and that whole work that was done about 20 years ago, I believe, is right now everybody's jumping up and down saying, oh my God, stem cells are so new, it's exciting. I remember when a company, which I think both you and I know, did the first stroke patient with their fetal-derived cells. So we made international news, stroke patient treated with fetal-derived cells. I can remember back when I was finishing high school, I believe, there was a company called Latent Biosciences, and they would be taking teratocarcinoma cells, differentiating them into neurons with transretinoic acid, and implanting them in the brain of stroke patients. And this was an FDA-approved study. So I think, just very quickly touching on politics, I think the FDA in general has been very kind historically to stem cell therapeutics. Just recently is when a lot of attention is focused on stem cells being popular, but I think people such as you, I mean, when I talk to colleagues, a lot of them don't even know about the great myoblast work that was done. How many people have been treated with myoblasts? Just getting back quickly to the myoblasts.
Well, it's in the matter of hundreds. This is one of the, from a personal standpoint, one of the sad stories, whereas virtually every other that I've been involved in, because it's still in progress and concepts are being nurtured. Myoblasts really never got a fair shake, in my opinion. We had a 331 patient study designed with 2 treatment arms, 2 different doses, and a placebo. So it was double-blinded. This was again sponsored by BioHeart, and the time was ripe. There was every reason to move forward in this direction, even though some of the surgical studies had been discontinued, one very prominent one. In any event, the company ran out of money, and we had to cease enrolling after 22, 23 patients. We nevertheless have some data that we've put into manuscript form and have submitted it because it will do 2 things to continue the myoblast work, and clearly there are skeptics for every cell phenotype and every cell product out there, and there's very good reason in some regards to be skeptical about skeletal myoblasts. I mean, they don't really replace cardiomyocytes. They don't become full-fledged cardiac muscle cells. Nevertheless, it's been shown, I think, fairly clearly, some basic scientists might disagree, that they, once implanted into a patient who has a very weak heart from multiple heart attacks, they do contribute to workload.
Now and they
do mechanics of the heart. So from the standpoint of their own biology, it would have been well worth completing that study. Still is well worth trying to complete that study. But the other reason that studies like that need to get done is that they set a platform. They set a new baseline for other muscle progenitors to model themselves on, and to learn from the mistakes or learn from the upsides of the study. And unfortunately, we've lost an opportunity to set a foundation, a benchmark. That I hope we will one day be able to recover. Quite the opposite is the case for most vasculogenic cells these days. I mean, as you have taken the time last week and since, critical limb ischemia is going, gangbusters for the most part for very good reasons. And it's interesting that the whole field in many respects began with the patient who had critical limb ischemia. Then people started becoming more interested, or shall I say, cardiologists got involved, cardiac surgeons got involved, and moved it, quickly above the diaphragm to treat patients with angina and chronic coronary disease and heart failure, leaving critical limb ischemia behind. And in the process, I think we lost some time. As you had the chance to talk, evaluating critical limb ischemia patients from an endpoint standpoint. What are we looking at and when are we going to measure it is so much less costly than evaluating the typical endpoints that one needs to assess for the cardiac studies, that it just made a whole lot more sense that we get back to this point. So I think the resurgence of critical limb ischemia in part has been fueled by a cost issue.
Now, so let me ask you, because to make sure that I understood this, so you said the field began with critical limb ischemia? Well,
I think, while I might not have the very early timelines down, some of the earliest administration of vascular progenitors were really in patients with critical limb ischemia.
The Japanese group? Do you mean the Japanese group?
Japanese group, right, in particular.
Okay. Yeah, that's
that. And angiogenesis, was the catchphrase.
Yeah.
Patients with chronic angina, patients with chronic pain in their legs. Heart failure wasn't really so much on the radar. But the same cells for the first two syndromes, as you well know, are likely to be very similar and very applicable. So from a business standpoint, it makes much more sense to enroll a large number of patients into a less costly study, looking at mechanisms that will later allow that same product, if approved, to then be applied to the heart. And that's probably the way we should have approached things, at the beginning.
Well, exactly. Now, let me ask some very, very quick questions, because a whole bunch of questions popped up here. Very quickly, somebody asked, are myoblasts preferable to mesenchymal stem cells? I don't know. I mean,
well, it depends on your perspective. I mean, there are precious few papers that would point toward mesenchymal cells, multipotent as they are, as really providing enough muscle, or being able to differentiate into cardiac muscle, as one had originally hoped from the earlier studies. So I say precious few papers. Those few papers are quite striking in terms of bone marrow-derived mesenchymal cells having the capacity, with minimal manipulation, to supplant heart muscle that's been lost. Nevertheless, it is the minority, and it's not really believed by many that the mechanism of those cells going into a heart that's got scar tissue or has been damaged in other ways are going to generate muscle. And if they do, it's based on the mechanism that you alluded to earlier, and that is the paracrine effects, the effects that the cells bring because they are little packets of growth factors. And the heart still does retain some capacity to regenerate. It just functions at a very low level. So mesenchymal cells can do that. If you really want to get muscle cells into the heart, you've got to start out with a good muscle progenitor. I don't think there's any other way around it.
Now, with that, that's a very interesting concept, because at the meeting, and especially after the meeting, at the party we had at your house, I met those guys from the company Cardio 3, I think, C3, the ones who who differentiate the stem cell into cardiac progenitors, and then they use them. And that reminded me also of the work of, I think, is it Eduardo Marban, the one who takes out from the heart, expands. So what you're saying is, in the stem cell area, there is some rationale for a superiority of using a differentiated cell as opposed to an undifferentiated cytokine factory. Would that be fair to say?
Very fair. Okay. Very fair. Especially when it comes to generating new muscle. And the sequence that I see occurring and perhaps becoming the path of treating patients with advanced myocardial disease is to first start out with the packets of growth factor cells, the mesenchymal cells, the bone marrow-derived cells, the adipose-derived cells that really don't have much of a prayer for becoming muscle cells themselves. And they're a little less differentiated. And then to see what one can accomplish by taking that step. Because we're seeing, and I think we'll get into it during this discussion, some very interesting results in terms of improvement in ventricular function using the vasculogenic type of cell. And then see what one can do, for example, in a large population of patients. And for those who have clearly lost a lot of muscle, with large heart attacks, for example, with dense scar tissue, we know that injecting mesenchymal cells into scar tissue really doesn't accomplish much. But it can stimulate muscle growth and angiogenesis surrounding it. So the first step would be to see what one can accomplish with a vasculogenic cell, a mesenchymal cell, for example. And then bring in the muscle.
Now, this is
because that may be what's left.
This is a very interesting point. Marzapan here, who's been commenting nonstop, asked us something which I've thought about a little bit before, which is, how important is the muscle loss in critical limb ischemia? Is it a significant problem, do you think?
I don't think it is, but I'd have to turn that question over to others who have more experience with that disease process.
Yeah, this whole business of muscle. The reason why it struck me is, I don't know if you remember, there was a study in Japan where, and even in the original Japanese one in Lancet, where they did the original big critical limb ischemia one. If you look at that study, when they injected the PBMCs as a control, there actually was some improvement. And then there was another study in Japan where they were injecting PBMCs in the muscle, peripheral blood mononuclear cells, and they were seeing some improvement. And then those people further demonstrated that it's actually the muscle, it's an interaction between the cells put in, like you said, paracrine, and the muscle was responsible for generating a lot of the cytokines, which I believe was IL-1 or 6. And they were able to neutralize that and show blocking angiogenesis. So I think the muscle, I don't know anything about the muscle, but I do get a feeling that the muscle in these cases might be a critical player in the dance of angiogenesis. Again, I'm just free associating here. Do you have any thoughts?
Yeah, it may well be. That's a very interesting thought. It's a very interesting thought. I don't know the answer to that.
Okay, here's another question.
It's been my sense, though, that there's not been a lot of muscle loss in these patients. There has been some atrophy, but there's reason to believe that atrophic muscle, when provided the right stimuli, be it in the heart or in the leg, can recover. So it's a good point, though.
Here's another interesting one. I think our friend who was at the conference from Juventus would have liked this question. Would it be possible to use myoblasts together with chemoattractants such as SDF1? Do myoblasts go to SDF1? Mark Penn, right? That was his name?
Yes.
Yeah.
Well, you are probably setting me up with a question that you know the answer to. One of the next generations of muscle cells, as few as there are right now, unfortunately, was an engineered myoblast, and it was engineered in a way to overexpress SDF1.
Okay.
And there were two investigators, as I understand the field, one being Mark Penn, who has been a brilliant investigator in terms of the SDF1, CXCR4 axis and homing. He created a myoblast that, indeed expressed SDF1. There was another group, I believe, out of Japan that did the same thing. The next study that was to be done under the sponsorship of BioHeart, perhaps even in parallel with that 300-patient study that I described to you, was to use those very engineered cells. So, yes, there's great conceptual and preclinical virtue that's been demonstrated in having myoblasts that do express SDF1, because they draw in a whole array of other cells that, in a sense, help them further their own growth and their own tasks.
There's some other questions here. There's a lot. Okay. Do high levels of matrix metalloproteases that we see in the ERC, so ERC are the endometrial regenerative cells that MediStem is working on, so this must be a MediStem supporter who wrote this. Do the high levels of matrix metalloproteases we see in the ERC, are they beneficial in fighting scar tissue in ischemic cardiomyopathy? Would they be of benefit for that?
Well, you didn't write that question, I assume. But I'd turn that over to you. I think there is great advantage to breaking down scar tissue for such processes, but let me hear what you would have to say about it, Tom.
Oh, thank you. No, my thoughts reflect, after we published with the ERC, a group from Japan published with a very similar, Yumazawa's group published with almost identical cell type, a couple of small molecular differences, but he demonstrated that when you inject them in the rat model post-infarct, there's actually less fibrosis with menstrual-derived mesenchymals versus bone marrow-derived mesenchymals. And this seemed to very strongly support this concept. In my mind, there would be certain advantages to the ERC in certain situations, but again, until we do big studies and figure out exactly how this is working, I think it's very difficult to say. But this brings up another question in my mind, which is, it's a question actually that a colleague brought up yesterday. We see so many types of mesenchymals, or even the definition of mesenchymal, I think, is becoming loose. on the one hand, we have the cells, like the cells that you've done some work with, the Arthrosis, the MAPC ones. We have Osiris, we have Allocure, we have Mesoblast. Do you think all these cells can be called in general mesenchymal, or do you think it's time that we start switching the word and start using another kind of definition, or going with specific definition? I mean, they all look similar. Your Arthrosis is smaller in size, I believe, but they're all adherent cells. They all have some potential. Do you think we should even be using the word mesenchymal, or?
I still think it's appropriate, but what I do think needs to happen is that there needs to be a very clear method for characterizing them beyond proprietary definitions. For example, in a meeting that followed the main IC 3D meeting last week, on Friday afternoon, we had a large session on critical limb ischemia, and the question came up, how do we distinguish one cell product from another? And it struck me that it would be very worthwhile to create a bank that would assess and profile each cell product, assuming that there's some homogeneity within each product, so that the company, the user, the reader of science would be able to formulate some impression about just what those cells express on their surface, just what they secrete, just how they might be different from each other. And they can all be within a mesenchymal, umbrella term, and yet they may have very important features that distinguish one from another. And that's what we really need to know. We need to be able to characterize them, not just from migratory capacity or other things that are measured, but just, in the same way that we can identify molecular structure of drugs, we need to be able to characterize these cells in a very clear and broad way, so that we know what to expect from them. Startup companies would, I think, benefit greatly by knowing the profiles of the 15 or 20 MSC products that are out there now.
Yeah, I agree. I agree 100%. We at our company, what we tried to do is we put ourselves commercially available, a research grade variant of the cells, and then with another company called Renovocyte, Dr. Bogan, our chairman, actually signed a deal where the cells are now being used for veterinary applications. So the exciting thing is, I think it's important that researchers have access, and us as companies, we let researchers publish, characterize the cells for us. I know as CEO of the company of MediStem, I would much rather find out on somebody else's buck that the cells have some properties that may make them non-desirable for certain diseases than find out in the clinical trial. But I agree 100% that we do need to have a big state of openness and dialogue, which cells have which phenotype, what they do, and so on. That leads me to, there's a question here from a patent lawyer.
Actually, let me just say one other thing beforehand. You might choose, and I don't take pleasure in holding up patent lawyer questions, so we'll get to that. But you might choose to alter your product at some point.
Yeah. And
you might choose to alter your product based on observations in clinical studies or other preclinical studies. Or you might choose to alter the properties of your cell based on what you see as existing in this whole grid of different cell products. And you're not necessarily going to know where it's going to end up fitting until you do that, and until you take it through that process. So I don't think we should look at MAPCs or your cells or any other cells necessarily as a stagnant product.
Yeah.
You're going to want to improve on it. And there are many ways that are turning out to be relatively simple to alter various aspects and properties of your cells. And you will be able to see that change if there is a large menu, a large profiling of cells out there. So I'm sorry, go ahead.
No, you're absolutely right, and this is what makes this field beautiful, is that even a simple process as a pulsing of the cells with hypoxia before administration, you can get those guys to migrate a lot better, and so definitely the cells that we have the IND filed for have different proprietary things than what are the cells that people are buying. No, with the patent lawyer question, it's very interesting, and obviously you don't have to comment on it, but the question is how do we know, and how will the patent office be able to differentiate between a lot of the cells? And we did an effort starting 4 years ago, and we ceased the effort about 1.5 years ago. It was called stemcellpatents.com. And stemcellpatents.com, I was talking with Ed Field yesterday from Aldergen, who he might be on the show in 2 weeks from now. I like to do these little fun type things for the field just for the sake of it. This show here is one of them, but we did this, basically we went on the USPTO site and compiled all of the patents that are issued that have the word stem cell in them and that have relevance to stem cells. So out of about 20,000 patents, we made a list of 1,600 patents, which then we broke down into patents on composition of matter, patents on methods of use, derivation, bioscaffolds, and I forgot what the other one is. The website's still available if you go on stemcellpatents.com, but this is the very, very interesting point. And the lawyer also asked about the case of Myriad, which recently they said that you cannot patent genes. The point, I think, is that we as an industry have to be very cognizant of the importance of intellectual property. And now I'm going to say something that's going to get a lot of people upset, but we cannot allow a lot of the liberal thinking or the type of thinking that some people are having that patents on stem cells are a bad thing, because they are not a bad thing. Well, nobody's saying that you own something in someone else's body. At least this is my opinion. But without having a properly functioning intellectual property system that has granted a different patent for Osiris and a different patent for Athersys and a different patent for Allocure, without having that, we're not going to be in business. And when I say we, I mean in general, who's going to be putting money in this field? And the dangers of this, very quickly before I stop my little rant, the dangers of this can be seen in Canada, where I originally came from, where in Canada, the Supreme Court in its wisdom blocked patents on transgenic animals. So if you were going in Canada and you were it was called the Harvard mouse, it was a case of the MIC-RAS double transgenic that developed spontaneous breast cancer. The Supreme Court was influenced by a couple of the amicus briefs that stated that the company, that Harvard was trying to patent life. And in this ruling, which was quite absurd, it put a significant strain on Canadian biotechnology. And back when I was in Canada, my ability not only to buy mice, but my ability today to send mice to collaborators because of different restrictions. So to our colleague, the patent lawyer, we obviously need good patent lawyers and a properly functioning patent system. I have a vested interest. Last point about this before I shut up is MediStem was the only regenerative medicine company to file an amicus brief in the case of Bilski, in which the Supreme Court was trying to ban patents on certain algorithms which could have implications in bioinformatics. But anyway, that was my 2 cents worth.
No, that was quite well put, and I'd like to say something that we could pick up the thread of later on, perhaps. But you have to realize that without the success of the small biotech company at this point in time, there will be no clinical trials. And the strength of the small biotech company rests solely on the strength of their patents. As it turns out, and this is a very much a pet peeve of mine, as long as we're airing pet peeves, allow me this. The government and governments of most countries do not fund clinical trials. There are notable exceptions. The Trials Research Network in stem cells in the U.S. Fund trials, but the speed with which clinical trials are going to get done is going to get done on the resources of investments and investors. And no one is going to invest in your company or in any other company that has, what the patent office feels is a fairly solid foothold on their IP, if they don't think that there is a future in it. So right now, the field rests, as I said, solely on this, and we're seeing a lot of problems starting up clinical trials in the U.S. because of the costs. And the more we drive up costs by not allowing patents to be issued and acted on, the more problematic we're going to have in running clinical studies. So it has a lot of ramifications in my opinion. It's a very important point that you raise and that the patent attorney raises.
Thank you. Alexei asked a question. I believe Alexei is a hematologist. By the way, before we ask this question, in general, has this field of stem cells moved? I mean, originally stem cells were being done by hematologists and are still being done by hematologists. Now we see a lot of different cardiac people moving into this space. Has there been any friction amongst that, or no, it's very cooperative? Well, that's not a proper question.
But, friction is a part of the life of the cardiologist, and we tend to, and that's said only partially tongue-in-cheek. We tend to quickly migrate and gravitate and sometimes usurp the work that, in my opinion, rightfully should be either jointly done or not done by cardiologists. Surprisingly, there's been enough of a distinction in role between the hematology community and anyone who chooses to use blood-related progenitor cells. There's a high degree of collaboration because, in a sense, they're entirely different strengths that are brought to the table by each group.
Yeah, no.
That's not been not that I've seen. That's not been a significant interference. In fact, there's been more positive interactions that have come from or between those two groups than negative.
No, the only reason I ask, and it's kind of funny, I sent out my usual spam email to everybody in my email box about the show, and I got quite a nasty email from a hematologist who was probably out there watching, asking who's getting compensated. And I said, well, do you mean is Dr. Sherman or am I? Or are you going to get compensated for having to watch this? And he was a hematologist, and then I thought maybe there was something between hematology and cardiology. But the great example of that, I was talking actually again with Ed Field yesterday, is Andy. I don't know if you know him. I think you probably know him. Andy Pecora. He's in New York, right? That's an example of a great
He's from he's in New Jersey.
In New Jersey, yeah. Hackensack. Right. And to me, that's an example of a great hematologist who saw a nice opportunity in cardiac, surrounded himself with people, got that license from Baxter, and basically single-handedly, originally set up this great company, Amersite, which that was... Okay, so getting back to Alexei, and I think Alexei is a hematologist, that's why I went off topic. He says, Dr. Sherman, what is the current status of trials using myoblasts in the heart? You touched upon that a little bit before. There was a publication about arrhythmias. Are myoblasts still, are they still a candidate? And do you see arrhythmias when you use bone marrows injected in the heart instead of myoblasts?
Right. No, that's an excellent question. It's been a characteristic of the cell and of those who have been working with that population of cells for many, many years. And I think the short answer is yes. There is a propensity for patients who receive myoblasts to develop ventricular arrhythmias during a period of time that spans 4 or 5 days after implantation, up to about 30 days. Now, as it turns out, early on when this started to be noticed, and this is where I can come clearly onto the side of the basic scientists, because certain of them, very brilliant ones, predicted this. Early on, several patients died from fatal ventricular arrhythmias. And we then came to realize that it might not be coincidence and that we needed to protect patients from this. And therefore, many myoblast studies had as a requirement that all patients have ICDs or defibrillators in place if they were to be considered for enrollment into the study. Now, you can look at that as a negative, and certainly on the surface it sounds that way, but the flip side is that the ability to generate an arrhythmia or the ability to participate in the formation or the sustaining of an arrhythmia implies that there's a living conductile cell present. And while this is pure hypothesis, there's just no data to substantiate it, many who support continuing work with myoblasts would look at the patients who develop arrhythmias as those who may very well have a successful engraftment. So, yes, it's a problem. And one of the other things that I can say, getting back to completing a 300-patient study, is that knowing how to manage arrhythmias, because this will be the case for every myogenic cell, even those that I imagine will form connecting bridges to native cells and express the appropriate connexins to do that, still there will be an arrhythmia risk. And until we set in place a relatively fail-safe mechanism to protect patients from this, then there really is no point in moving forward, or there's less ability to move forward quickly when it comes to other muscle-based cells. So yes, it is a problem. Yes, in the past it has had serious consequences for a very few number of patients. There are those who disagree with what I've said and feel that there is no arrhythmogenicity. But we believe, even from the 21 patients that we enrolled into the MARVEL study, that we know how to prevent this and treat it when it happens, such that patients survive and may perhaps have as good or better outcomes as those who didn't develop the arrhythmia. But it's an issue, and there's no no other way to look at it as one that needs to be understood and addressed.
Okay, very quickly, a couple last questions. We only have about 5 more minutes left. Is there any stem cell work being done at Columbia in Parkinson's, in patients?
I'm not aware of an active trial at the moment, but if whoever asked the question would want to email me, I can get back to them about that.
Okay, great. There's a discussion going on here about on the people chatting about stem cells being available in pill form. If you could ever make a stem cell pill, and it's very funny because we published a paper on a stem cell nutrient. It's basically a combination of different antioxidants, and we published increase in circulating EPCs. And why this is funny and why I'm laughing my head off is where we are filming this right now is at Raj's place, and I saw a bottle of the actual thing. It's called Stemkine. So
I was waiting for this.
it's very funny, but of course, I mean the issue is I'm sure you've seen those studies. People that smoke, for example, have less EPCs, if you want to call EPCs stem cells, and I think it would make sense if you take different nutrition, some stem cells would increase. This one seemed to be very potent. We published that, but okay. And
I think I would. Maybe I'm talking too much, but I would support the concept that the very same processes that we try to induce by injecting non-cellular agents to stimulate cell processes may well be able to be taken orally.
Yeah.
And a lot of the medications that we know are good for cholesterol, for example, are also known to enhance EPC function. So some of the benefits may be there from oral medications.
Do you think I should take one live?
I think it would be a wonderful thing, and just make it through the rest of the transmission.
Okay. There's another question here. We have a trial soon at Jefferson where we believe we can disaggregate alpha-synuclein. These patients are excellent candidates for stem cells. I don't even know what that is, alpha-synuclein.
I'm with you on that.
Okay.
Maybe that question, the person who posed that question could educate us about that.
Yeah, can that person tell us what that is? Okay, and one last area that people are asking about is the use of stem cells offshore, and this whole ISSCR attack on offshore stem cell clinics. My opinion, I think, is, as we saw at the conference, somebody asked a question, if stem cells are being used according to proper regulations by the local government, I don't really know what the issue is, but I don't know. Do you have any opinions on that, or?
I have a lot of opinions on that, and I'm going to cause this to run out of time, but just to make 2 points. One is we have to have a mechanism of oversight of each of these facilities. Many are purely and solely money-making propositions, and the material that's given, the product cells that are given are not characterized, and these organizations do not publish their data. So from that standpoint, it's awful. From a practical standpoint, patients have nowhere else to go in the U.S., especially with the shortage of studies done. I do take issue, and I'll probably catch some email heat over this tomorrow, with organizations like ISSCR taking a stance on this. This is not a clinical organization. In my opinion, they have no business whatsoever in trying to regulate what's going on offshore on their own. They need to get together with clinical organizations such that it can be done in a much more cohesive way.
No, I agree 100%, and I was being interviewed by Nature 3 days ago, and that's exactly the same point I told them. I said, MediStem licensed some of its technologies to one of the clinics offshore. And I said, you know, if there was a group of people like Emerson Perrin or such as yourself or Amit Patel that would go and say what you guys are doing is bad, I can guarantee you the clinic that we collaborate with would pack up its shop and go home, because people like what you're doing and what Amit Patel is doing and Emerson Perrin and these folks, they're in the position to judge, not certain other people that play in the lab all the time. But anyway, okay, that's something, that's another issue for another day. Dr. Sherman, thank you very much for your time.
Thank you.
Any last comments you want to say before we sign out?
No, well, yes. I think you're doing a great service, actually, not by having me on, but by having people on that, in general, can have an open dialogue about this. It's been sequestered from the public eye for far too long, and the way you seem to run this particular session and these sessions, I saw the one with the meat, is really quite engaging. There's very little misrepresentation, if any, that I can detect, and this is just what needs to happen. I mean, this is the equivalent of the town hall, and I want to thank you for doing that.
Yes, thank you very much. The point was what you said about the myoblast trial not being continued because of lack of funding. I believe if we come across as a community with the patients, with the companies, and put forth the great potential of what everybody in this field is doing, the public loves this. The public just doesn't know. So thank you very much, and thank you to everybody who was tuned in.